Good morning, everyone. Hello, and thank you so much for joining today. This webinar is part of the Provincial COVID Rehabilitation and Allied Health Provider Education Series. Today, we will be discussing the topic of neurocognitive sequelae, functional cognition, and cognitive communication considerations after COVID-19. My name is Carmen, and I'll be moderating the session today. We're very excited to have such great interest in these sessions. Because of the high number of participants, we ask you to please keep your audio lines muted. Please use the chat function to type in any questions. You can find that at the bottom of your screen near the middle. Please use a direct message to questions, which is myself, Carmen, and I will send a message to the group in just a moment for you to have easy access to that. I will collect the questions and bring them forward at the end of the session. Please note that this webinar, along with the question and answer period, is being recorded. Recordings will be posted on our web pages, and I'll add those links in the chat box shortly. This webinar series is open to all healthcare providers. These sessions use a biopsychosocial spiritual lens. You are encouraged to tune into as many sessions as possible. They've all been recorded and there's still a few more to happen after today's, as we believe that each session will be an opportunity for new learning. There's also a written companion clinical resource that will be updated as new information or content becomes available about COVID-19 research and rehabilitation. I'm very pleased to introduce our speakers today who are experts in cognition. Dr. Samita Schwartzberg, neuropsychologist at the Glenrose Rehabilitation Hospital. Dr. Stuart Longman, rehabilitation psychologist at the Foothills Hospital. Judy Zaldes, occupational therapist at the Community Accessible Rehabilitation Program. And Kevin Linland, professional practice lead speech language pathology for the Calgary Zone. And we'd also like to thank Yolan, Anna, and Megan for their contributions in the literature review and development of today's session. The information provided in this webinar is intended for an AHS audience. Other staff groups may find the material applicable, but are responsible for aligning it with their own clinical policies and procedures. Every effort has been made to incorporate the best current evidence and information available. Please keep in mind that information and new evidence, particularly regarding COVID-19, emerges frequently. If you have questions or concerns, please feel free to contact us at Practice Consultation. And we'd like to acknowledge that we are gathered virtually today on the territories of Treaty 6, Treaty 7, and Treaty 8, and Métis Regions 1 through 6. These territories are home to many Indigenous peoples, including the Blackfoot, Cree, Dene, Tsuut'ina, Ojibwe, Stoney Nakoda Sioux, and the Tsuut'ina peoples, the Métis nations of Alberta, and the 8 Métis settlements. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. And with that, I'll pass it to you, Dr. Schwartzberg.
Thank you very much. So today we will be covering a number of different topics: COVID-19 and neuropsychology, neurocognitive changes, screening assessment, cognitive treatment. There will be a few case scenarios, functional cognition discussion, as well as cognitive communication. Next slide. All right. We do know that a number of different organs and organ systems can be affected by COVID-19, including the lungs, the heart, the digestive systems. There is also evidence, though, that the central nervous system, or CNS, can be affected, either directly via encephalitis or infection mechanisms, which I'll get to in a minute, or indirectly via secondary neurological processes such as stroke or hypoxia. There have been reports of COVID-19 patients experiencing neurological symptoms like anosmia, encephalopathy, myelitis, seizures, as well as cognitive problems. But we don't yet know much about the cognitive patterns associated with COVID-19. Next slide. This slide just shows some potential mechanisms of CNS infection. We know that COVID, or it's thought that COVID-19 is an airborne virus, and it gets into the cells by binding possibly to the protein ACE2. And ACE2 receptors have been found in a number of different brain areas, including the brain stem, the cortex, striatum, and hypothalamus. Another possible mechanism is entry into the olfactory bulb, which might explain why a number of COVID-19 patients do experience a loss of smell. Next slide. Next slide, please. Okay. In the Bailey et al.'s review, it was they provided evidence that in other previous coronaviruses like MERS, the Middle Eastern Respiratory Syndrome, neuroimaging studies showed extensive changes in a number of different brain areas, frontal and temporal and parietal lobes bilaterally, as well as in periventricular white matter, basal ganglia, corpus callosum, midbrain structures, cerebellum, pons, and cervical cord. There was also evidence in these studies that patients had pre-existing vascular risk factors like diabetes, hypertension, ischemic heart disease, and dyslipidemia. Other evidence that was covered in that review showed that patients with that stroke, encephalitis, and hypoxia may occur after COVID-19. And there were reports of individuals with pre-existing neurological conditions like a stroke earlier on that went on to develop COVID-19. There's the possibility that those with comorbidities may have a more severe form of the illness. Next slide. There's also evidence that patients with severe COVID-19 infection had significantly greater incidence of acute cerebrovascular disease, skeletal muscle injury, and disturbance of consciousness. In addition, those severe patients with neurological symptoms had greater immune and metabolic disturbances than those severe patients without neurological symptoms. Other research shows that there is an increased cerebrovascular risk in patients with COVID-19. Next slide. In studies of COVID-19, as well as other coronaviruses, it's been shown that when the brain is directly affected, there may be an exacerbation of cognitive problems in those with known cognitive problems already, and that cognitive problems may also be magnified by secondary or tertiary systemic dysfunction, as in patients who've had renal failure, hypoxemia, hyperactive immune system, or cardiovascular compromise. And given the extent of systemic dysfunction in COVID-19, it's not surprising that cognitive outcomes are expected to be varied. We would expect more minimal effects on the brain with milder COVID-19 cases, more short and long-term cognitive or neuropsychological difficulties in those with severe or critical COVID-19, and those with pre-existing cognitive or medical comorbidities may also show greater and more prolonged neuropsychological difficulties. Next slide, please. The expected cognitive pattern was discussed in a recent webinar that I attended a few months ago, given by Barbara Wilson, and as well as discussed in this review article by Bailey. And the expectation is to see a more generalized or global neuropsychological pattern that would affect a number of different cognitive domains: attention, processing speed, learning, memory, and executive dysfunction. And in cases where there have been seizures or vascular events, we might also find more focal deficits, such as visual neglect, apraxia, dysnomia. It's expected that cognitive problems will occur largely in people with known neurological illness associated with COVID-19, but those without any obvious neurological illness might also experience both cognitive and emotional problems, in addition to fatigue, deconditioning, and breathing issues. Bottom line is that we don't expect there to be one cognitive picture. We expect to see different patterns. Next slide. And other contributory factors that we should take into consideration is that we expect that COVID-19 patients, especially when they're in the acute and post-acute phases, will show significant fatigue. And in reports of case studies to date, where patients had problems with both concentration and memory, fatigue was also a big issue. And it might be that fatigue may be contributing significantly to those cognitive problems as well. Psychological issues in COVID-19, such as low mood, anxiety, PTSD, adjustment problems, may also contribute to the cognitive picture. Next slide. There's a subset of individuals who are known as having long COVID or they're known as long haulers, might experience persisting symptoms in the post-acute phase, similar to those with chronic post-SARS syndrome that have been seen in the past. A number of different symptoms like chronic malaise, diffuse myalgia, symptoms of low mood and non-restorative sleep, as well as headaches, loss of taste and smell, and cognitive impairment. This might occur for up to 10% of COVID-19 patients. We don't know yet. And these may be in patients who've had serious medical complications, as well as others who experience a prolonged set of symptoms that are nonspecific after a relatively milder illness. The reasons for long COVID are not known yet, but it has been hypothesized that perhaps there's still a low level of virus circulating in the body. There may be an autoimmune etiology, or there may be mitochondrial disease, or some combination of all of these things. And at this point, it's unclear what types of problems these patients will have, how many will be affected, or how long the problems will last. But it's important to understand possible cognitive outcomes in the COVID-19 population. The early research suggests cognitive symptoms may occur and persist even after recovery. But at this point, the short and long-term cognitive impacts remain largely unknown, and time will tell. And I will pass it on to Dr. Longman.
Thank you. And I will admit here to some biases in my presentation, because to date, our program has seen those patients with severe issues, severe physical issues, and so biased to people with pronounced neurological involvement. Bearing that in mind, the literature says, as you've already heard, that the likelihood of neurocognitive changes really varies with illness severity. Neurocognitive concerns can be seen in half or more of patients after hospitalization, can be seen in perhaps a fifth or a sixth of outpatients who are symptomatic but did not require hospitalization, while surveys of asymptomatic non-patients, but individuals who've tested positive, still find that between 2 and 8% are reporting cognitive concerns. And we know that these issues may persist. So one study looking at a group of 20% of outpatients identified cognitive concerns at while they were acutely symptomatic, but even after several months, still about 8% were reporting cognitive symptoms. And these are seen as happening most in the areas of executive skills, attention, and memory, again, as we might expect for a vascular neurocognitive presentation. Okay. Next slide, please. Here, this is comparing symptom reports at 4 weeks post-illness onset and at 3 months post-illness onset. Fatigue is the greatest concern, but cognitive concerns are still seen in about 12% of patients at 4 weeks and again at 3 months. These things are not going away quickly. Now, for the next slide, please. Okay. Now, we know that screening tools may not always identify issues. That's true for cognitive concerns in general, comparing screening tools versus longer formal assessments. We also know it's important to choose the right screening tool for your population. So, for example, if you're looking at outpatients who haven't required hospitalization or who are not showing gross cognitive changes, a somewhat more comprehensive and in-depth tool such as the ACE-3 or the SCIP seems to be the tool of choice. There's been some recent studies out of Scandinavian countries looking at the SCIP in younger adults and people looking at return to work, finding both that this is a useful tool and that a larger proportion of folks are showing cognitive disorders than we might have expected. For older adults, the slums or the RUDAS appears quite appropriate. Following on last week's presentation on social determinants of health, we do know that COVID infections are more prevalent and they're more likely to lead to serious consequences in immigrant, impoverished, and indigenous populations. In those cases, the RUDAS, for example, may be a useful tool based on cultural factors, or the slums may be a useful tool depending on age. Okay. Next slide, please. In terms of who we need to screen and assess, number one, we should screen everybody who's at high risk of cognitive concerns. So if somebody's been hospitalized, particularly if they've had neurological consequences, we want to screen. That's not a question. And very likely we want to assess. If there are collateral reports of cognitive difficulties, again, we want to screen, but with strong likelihood of assessment. What do we want to look at? Memory, complex attention, executive skills. You've heard that 3 or 4 times now, so bear that in mind. And when we want to do this prior to the patient, our client, when they are not yet increasing cognitive demand for work or school or increasing community activities, because we want to prevent difficulties rather than demonstrate that, yes, we know why they're having difficulties. As well, because people are often reporting impact of cognitive fatigue, we want to consider what time of day or what time of week we want to do this. People may do better at noon on a Monday than they do at 3 o'clock on a Friday, for example. Next slide, please. I'll put this up here. I won't go through all of this, but as you might expect, there's no magic recommendations that are specific to COVID infections. What we know is that using tools that our patients are familiar with, emphasizing cognitive scaffolding, just reminders of approaches to do tasks, increasing homework, increasing complexity, and emphasizing the relevance for this person in their life. Next slide, please. Thank you. I'm going to talk briefly about Ed. This is an patient that we've spent a great deal of work on in terms of assessment, in terms of treatment. We've got a very lengthy description that I'm actually going to fly over. But Anna Marino is the occupational therapist who has done the most work with him in his neurorehabilitation stay, and I've stolen heavily from her. But like a lot of patients at risk, he's 72 years old. He has comorbid medical history, including diabetes, obesity, some cardiac issues. He continues to run and own his own business. He was diagnosed with COVID-19 in early December in that big wave, and he was subsequently admitted to hospital with a long ICU stay, in fact, 2 long ICU stays, and multiple medical issues. Cognitive issues were identified early on. He was delirious. He did develop critical illness myopathy. And fortunately, he was able to come to our rehabilitation unit in late March. Next slide, please. So on admission, he's oriented but showed significant challenges with memory, attention, executive skills, processing speed as well. And cognitive screening certainly identified, significant cognitive impairments that would be expected to affect his functioning. However, he also had greatly limited physical functioning, which was a much higher focus for services at first. Next slide, please. Now, as Ed continued to improve, it was important to look more at cognitive functioning. Could I have our next slide, please? There we go. And so on neuropsychological assessment, he did show severe cognitive deficits in memory, attention, processing speed. He showed little identification of deficits, while he showed mild visual perceptual deficits. And his family had not identified deficits. They hadn't had the opportunity, given as they haven't been able to actually see him. They're hearing from him, they're hearing his story. That's an issue for our hospitalized patients, that we need to work on family information and education. So diagnosis was major neurocognitive vascular disorder, and this looked much more like a diffuse neurocognitive disease than a focal stroke. So even though stroke was identified on imaging, the neuroradiologist raised the suspicion that this may have been a previous finding rather than something that occurred during this hospitalization. We don't know, unfortunately. Again, using a great deal of practice, repetition, feedback, focusing on using strategies in context, and particularly allowing time has been really important for his rehabilitation. Next slide, please. And fortunately, he is leaving us. He is showing cognitive improvements, although he continues to demonstrate mild to moderate memory impairments. He's recording strategies both for his own purposes and for his family education. As he attends outpatient services, he'll have a comprehensive discharge summary, and we intend to get early feedback from his family on functioning at home to aid planning for further discharge and outpatient therapies. And next slide, please. Thank you. That's it for me. And now for Judy.
Thank you, Stuart. So far, we've discussed what we can expect in terms of neurocognitive changes in our post-COVID population. Stuart introduced a very interesting case example of a patient and his journey within an inpatient setting. And he mentioned the tools and interventions that have helped him progress towards discharge home. We also need to consider how a client's cognitive presentation may vary depending on where the client presents along the continuum of care. At different points in recovery, post-COVID clients will require different discipline-specific services in order to progress and achieve their goals. The client previously discussed will require ongoing services once he is discharged from an acute care setting. The Community Accessible Rehabilitation Program, also known as CAR, is just one community-based program in Calgary offering services to post-COVID clients that meet certain eligibility criteria. As an occupational therapist with the CAR program, my role involves assessing and treating clients who are referred to our neurostream based on ongoing functional issues that are neurological in nature. For our post-COVID population, barriers to function may be cognitive, physical, communication-related, symptom-related, or all of the above. The provision of community outpatient and specialized rehabilitation services is very important for post-COVID clients as they transition back to their previous activities. Many of these individuals will encounter functional challenges due to persisting symptoms and changes to their abilities, and they're going to look to our community healthcare providers for guidance. Next slide, please.
Judy, I'll have you continue, but Kevin, unfortunately, we're not seeing the top and bottom of the slide. It's getting a bit cut off. If you don't mind trying to correct that as Judy, please continue.
So, will there be clients presenting with cognitive issues? Literature regarding cognitive impact of COVID-19 is still very limited. However, there have been several studies which evaluate cognitive deficits among subacute COVID-19 and post-COVID-19 patients. I'm not going to run through the research in detail, but the main findings indicate that yes, both groups do show signs of cognitive dysfunction and that these issues do persist past the point of infection. This necessitates the need for community, outpatient, and specialized rehabilitation services to address the needs of clients who continue to experience cognitive changes. Next slide, please. So working in outpatient rehab as an occupational therapist, my focus is on learning how post-COVID cognitive changes may impact what a client can or cannot do functionally, and what this means for their life roles and responsibilities. This is going to be different for each and every client. You can imagine that rehab goals are going to look very different for a client who becomes ill in their 30s and has a disruption to their productive work life and their family life, compared to a client in their 70s who has different leisure and productivity priorities. Formally, the definition of functional cognition is looking at how an individual utilizes and integrates his or her thinking and processing skills to accomplish everyday activities in clinical and community environments. What we know is that clients who have had COVID-19 may experience temporary or permanent changes to their cognitive abilities, and that these changes may be more or less apparent and more or less troublesome at different points in their recovery. To complicate things further, we know that fatigue, deconditioning, anxiety, and other factors may also complicate how a client presents from a cognitive perspective. These factors may become more relevant when a client is accessing services in the community. For example, a client may experience more fatigue in the home environment when they exert themselves too much based on their own expectations, and this may result in an exacerbation of previous symptoms. It's also well known that anxiety and depression can also affect cognitive performance, and that this might be heightened at the point when a client must deal with the pressures of adjusting back to pre-illness roles while also trying to manage less energy and persisting symptoms such as shortness of breath. Therefore, cognitive rehab cannot happen without consideration of how these variables are potentially impacting a client's cognitive processes and their own perception of their thinking skills. Next slide, please. So depending on the severity of a client's course of illness, he or she may require different levels of support in the community. In a previous seminar, we learned about various tools that help to determine how we can help clients recover from COVID-19. There are tools ranging from self-management education guides to more personalized rehab options. The Post-COVID Functional Status Scale, or the PCFS, is just one tool that can help guide clinicians on how a client's needs can be most effectively addressed. I'd encourage listeners to look back on previous seminar topics for a more comprehensive overview of this tool, especially for those who may be referring clients to community services. For my purposes today, I'm referring back to this tool as it's relevant to the case study that I'm going to introduce. This client featured in this case study would be categorized as a grade 4 on the PCFS, which means that she was experiencing severe functional limitations at the time that she was referred to the CAR program. A grade 3 or 4 on the PCFS does warrant personalized rehabilitation from a multidisciplinary team. This case in particular highlights many variables that need to be considered when assessing a client's cognitive presentation within a community rehab setting. It's important to remember that this is just one example and that many clients will present quite differently and will require different intervention. Next slide, please. So our case study is about Edna. She is a 70-year-old female originally from Colombia with a history of hypothyroidism, but was otherwise healthy. Edna tested positive for COVID-19 and was admitted to hospital in December after worsening respiratory symptoms. She stayed approximately 45 days in the ICU, and this stay required intubation, mechanical ventilation, and tracheotomy. During this time, she sustained complications including acute kidney injury, bilateral pulmonary embolism, UTI, and ventilator-acquired pneumonia. She was followed by neurology for possible COVID-19 related hemorrhagic leukoencephalopathy, and there were MRI findings. This client remained in persistent coma until the end of January 2021. Next slide, please. Fortunately for Edna, there was a change of events and she did emerge from her coma. At that point, an EMG did demonstrate ICU-associated polyneuropathy and myopathy. She was transferred to a medicine unit, and at that point, she was considered to be quite a heavy client. She required a lift transfer, and she required assistance with all of her basic activities of daily living. Edna had a low tolerance for activity, but she did begin to participate in therapies, and this prompted a physiatry consult, at which point she was waitlisted for tertiary neuro rehab at the Foothills Hospital. Edna was actually discharged from hospital to home after her family expressed a preference to care for her from a home environment. And at that point, she was referred to community accessible rehab for ongoing rehab. Next slide, please. So as an occupational therapist, I did the intake with Edna, and this was completed over the phone with the goal of capturing how Edna was doing from a functional perspective. Some common themes which arose through the intake were fatigue, deconditioning, and anxiety. Edna was participating in her basic activities of daily living, but she required assistance from family. She could shower from a seated position with equipment, but she fatigued quickly and she could not complete more strenuous tasks, such as washing her hair. Edna could only stand for short periods of time due to fatigue. She could dress herself slowly from seated, and she required a transfer belt to walk around at home. Edna was very terrified of falling, and she didn't trust her legs. Fortunately, one of her main supports at home included a daughter who was a nurse, but even her daughter identified that it was challenging to know how to progress her mother. She felt that her mother was not pushing herself enough. So Edna reflected on her own perspective throughout the intake, but since English was not her first language, her daughter also shared her views. It was quite clear that the family and the client were quite stressed about the uncertainty associated with Edna's recovery and whether she would ever get back to normal again. So what could Edna do functionally? Well, she was able to keep track of her medications. Her daughter was keeping track of her appointments, and Edna was hesitant to take over this task because she felt that if she became more involved in her own care, that others would stop taking care of her. When asked about her thinking skills, Edna reported that it was very challenging to concentrate. She also felt that her memory wasn't as sharp. She perseverated on an example of trying to recall what she had for breakfast and not being able to remember, and to her this was very stressful. When asked when she noticed these cognitive challenges, Edna reported that they were much worse when she was tired. We also talked about her sleep routine, and Edna shared that she frequently experienced nightmares. This seems to be common of more complex medical post-COVID clients who were in a coma. She also endorsed anxiety related to getting sick again, and for that reason, she had a great fear of going out into the community. So these are just a few things that were discussed during her intake and helped to determine that Edna would benefit from personalized occupational therapy, physiotherapy, and social work involvement in her rehabilitation. Next slide, please. So it's reasonable to think that assessment and treatment for this client could be approached from different directions. In summary, this client's treatment consisted of reflection on current sleep habits and discussing sleep hygiene and practices that could optimize the client's rest at night. The client acknowledged that it was more challenging to concentrate and remember information when she was tired. So discussing how both her body and brain require adequate rest was a good first topic to cover. We also discussed energy conservation, energy maximization, and pacing. This included a focus on the importance of rest breaks during both cognitive and physical tasks. We talked about activity grading. This focused on helping the client learn how she could participate in tasks such as cooking without doing the whole task, or modifying the task so she could do it from seated while not expending as much energy. We also focused on activity scheduling. So that taught the client to be more mindful of how she felt on a daily basis in terms of her energy level and scheduling her day so she doesn't overdo it. This involved incorporation of a daily planner and the concept of pre-planning her day. We also reviewed compensatory memory strategies in order for the client to feel more organized and in control. Additionally, we talked about attention, and we reviewed things like sticking to one task at a time, reducing distraction, and taking breaks as needed. All sessions included attendance of a family member so that the client could successfully apply what we discussed in her routine at home. Now, in terms of formal cognitive assessment, I don't think there's any ideal set of cognitive assessment tools that should be used with post-COVID clients. Tools should be selected based on listening to your client and trying to gain an appreciation for when they are having functional performance issues. Timing of administering such tools should be sensitive to other factors that may affect performance, such as fatigue and anxiety. Now, a cognitive screen will give limited detailed information, but might be a good start if the client has poor insight and awareness and identifies no cognitive issues, even when a discharge report from acute care or family suggest otherwise. For this client in particular, I did administer several assessments. We started with the SLUMS, or the St. Louis Mental Examination. So that's a cognitive screen, and she scored 25 out of 30, which is considered borderline and may indicate mild cognitive impairment. This score was interpreted with caution as the client is ESL, and her daughter was present for all cognitive assessments. After the cognitive screen, she did provide feedback that she thought the client's performance was reflective of baseline abilities and that English was the limiting factor. Other assessments that were administered included the behavioral assessment of the dysexecutive syndrome, also known as the BADS, and this was administered in a modified format. The client was observed to do quite well on subtests problem solving and did demonstrate that she could manage multiple tasks at once while abiding by a set of rules. The client did well on other brief standardized assessments of executive functioning, such as Charles A and B, by making no errors, although her timing score was a bit longer for Charles B. I also administered other tools such as the MVPT, or the Motor Free Visual Perception Test. We also looked at the Dynavision Performance Assessment Battery and the Useful Field of View. And on all of these assessments, she did score within normal range. Additionally, within our treatment sessions, I frequently reflected with both the client and her family on how things were going at home to figure out if there were any recurring cognitive challenges that were a barrier to function within the home or community environment. Next slide, please. So one of the most important considerations throughout the process of providing multidisciplinary outpatient rehab is figuring out, is my intervention actually helping this client in their recovery? So for this client, progress has taken time, but after 3 months, she has made significant gains. She walks independently without a gait aid after having consistent physiotherapy intervention. She continues to struggle from fatigue and low energy, but she's feeling stronger and she feels way more in control of managing her energy fluctuations. The client is independent with her daily routine, so she performs all self-care independently. She manages her medications, and she's the one anticipating upcoming appointments and reminding her daughter of them. She appears less bothered by occasional forgetfulness, and she effectively problem solves how she can use strategies to decrease the frequency of these. She no longer catastrophizes these occurrences. She's also participating in meal preparation tasks, and there are no safety or functional issues. This client has returned to her leisure pursuits. She's participating in embroidery projects, has returned to gardening in a modified capacity, and both her and her daughter feel that there aren't any obvious cognitive barriers to her participating in functional tasks in general. This client has identified that a future goal will be to return to driving at some point, but she does want to continue to get stronger first, and she is demonstrating good insight in knowing that there's no rush. Another important point is to mention that family and the client seem to be on the same page with how to progress the client, and there's less uncertainty about doing too much versus doing too little. So I've painted a pretty rosy picture of this client's recovery, but there are still ongoing barriers. This client still has poor energy and ongoing anxiety. She's required regular medical follow-ups, and there's been other solutions, such as going on an antidepressant, that have worked quite well for her. She has developed new back pain that continues to slow progress and is a new barrier to task performance. She also continues to have dizziness with movement. So basically, this client continues to have good and bad days, but overall, she does feel more in control with the tools that she's learned. My last point on the slide is that for this client and for other clients, progress won't necessarily be linear. So therapists should be prepared to review the tools that can be helpful and to provide reassurance that recovery takes time and that expectations and timelines might need to be adjusted. Next slide, please. So this was just one case study of a client's journey so far, and her recovery may continue for quite some time. She seems to have mild, if any, cognitive deficits, and these don't seem to have a significant impact on her day-to-day functioning. The purpose of sharing this case study is to illustrate how important it will be to assess cognition within the context of other variables that may be quite common for the post-COVID population. So just a few quick take-home points for our audience today. Make sure you listen to your clients. The client is the expert of their own illness experience, so it's very important to learn their perspective on their cognitive functioning, because this will tell you a lot. Involve family when possible. So collateral information can be helpful in teasing out what to focus on during your assessment and treatment. Consider the multitude of factors and variables that may affect a client's cognitive presentation, as those actually might require attention first before you start your standardized testing. Also understand the role of your colleagues within a multidisciplinary team environment. This is important for when there are significant barriers in a certain area, which may be preventing progress in another. Another point is that we need to rely on what we do know from treating complex medical patients and continue to be holistic in our approach to understanding a client's well-being and needs. You can balance this with your own clinical judgment and then objectively evaluate cognition. And knowledge sharing, share what works, because we're all still very limited in what we've learned. And if we share what we know, we can all try and figure this out together. So speaking of working together, our next speaker, Kevin, will lead us into a conversation about cognitive communication and its relevance to our post-COVID clients.
Great, thanks, Judy. Yes, we're going to finish up today with a brief overview of cognitive communication disorders in the context of patients recovering from COVID-19. Cognitive communication disorders are defined as impairments in a person's communication abilities that result from underlying cognitive impairments. Difficulties with attention, memory, or processing speed, for example, can have a significant impact on a person's ability to reliably comprehend spoken and written information, to speak clearly and concisely, or to interact in a socially appropriate manner. Individuals with cognitive communication impairments frequently exhibit communication difficulties that include difficulty retaining and recalling spoken and written information, using language to help them with problem solving and reasoning, being able to efficiently switch between topics or activities, the ability to retrieve words in a timely and accurate manner, and also the ability to interact in a socially appropriate manner. This is a model of how a person's communication abilities are affected by a complex and dynamic interplay between cognitive, emotional, physical, and communication processes. All of these processes can be affected in individuals who are recovering from COVID-19. Varying degrees of temporary and permanent brain damage can occur in patients with COVID-19 due to intermittent or chronic hypoxia resulting from acute respiratory distress syndrome, and also from inflammation and or coagulation within the vascular system that results from the immune system's response to the COVID-19 virus. This brain damage can result in cognitive and emotional disturbances that have a direct impact on an individual's communication. COVID-19 related brain damage can also impact areas of the brain that are specifically involved in language processing. Psychological diagnoses such as depression, anxiety, and PTSD are commonly reported in patients recovering from COVID-19, and they're associated with cognitive impairments in attention, working memory, information processing speed, and executive functions. In addition, a number of physical factors, such as respiratory impairment, sleep disturbance, fatigue, hearing and visual changes, can have an impact on COVID patients' ability to communicate effectively. So just briefly, here's a case example of a COVID patient who presented with cognitive communication impairments. Cornelius was a 67-year-old man with an unremarkable medical history. He was originally from China and his first language was Mandarin. He had lived in Canada for more than 20 years and he spoke English with a fair degree of proficiency. On April 2nd, he presented to the hospital and was diagnosed with post-COVID-19 pneumonia. At that time, he returned home, but quickly developed worsening shortness of breath and was admitted to the hospital on April 9th. His oxygen saturations at that time were at 50%, and so he was intubated. On April 22nd, he was extubated, but quickly exhibited a reduced level of consciousness and was reintubated. And then on April 29th, he was extubated a second time and moved from ICU to a general medicine unit. MRI studies of Cornelius's brain that were done at the end of April showed that he had bilateral posterior cerebral artery infarcts that were affecting the left occipital pole and a smaller right occipital cortical and subcortical area. He also demonstrated bilateral damage to his hippocampus. Left-sided hypodensities on the MRI were felt to be consistent with a diagnosis of posterior reversible encephalopathic syndrome, also known as PRES. So on admission to rehab on May 20th, Cornelius was very disoriented to year. He couldn't route find on his medical unit, and he had no recollection of the COVID-19 pandemic. He expressed some awareness of his memory deficits. His language impairments were more pronounced in English than they were in Mandarin, but they were still very significant in both languages. He had difficulties understanding simple yes/no questions, difficulty following 1 to 2 step spoken commands, and trouble retrieving commonly used words in a timely and accurate manner. He also displayed restless, impulsive behavior and evidence of a right visual field loss. Speech pathologists administered the Western Aphasia Battery to test his language. They also administered the BUT test of nonverbal reasoning. It was initially completed in English and then done a second time with a virtual Mandarin interpreter. Testing in both languages reveals significant cognitive communication impairments, resulting in behaviors that included frequent need for tasks to be repeated, frequent need for the patient to be redirected. He had a lot of difficulty switching from one task to another. His verbal output was very tangential. He made a lot of impulsive comments and responses. And when he was trying to tell stories or describe pictures, his output was very disorganized, very repetitive. Cornelius's comprehension of simple spoken yes/no questions in Mandarin was less than 75% accurate and significantly less so in English. He was able to follow short, simple commands, but as soon as these commands became lengthier or more complex, he really struggled. His verbal expression of his ideas in either language was impacted by ongoing word retrieval difficulties. The speech pathologist focused Cornelius's communication treatment on trying to improve his comprehension of yes/no questions, to be able to read at a single word level, and to be able to problem solve in everyday situations. They provided care providers and family with instructions to support his comprehension and expression that included the use of a Mandarin interpreter whenever information that was very important needed to be shared with him, speaking to him in slow, simple sentences, and writing down key words to augment spoken information. And finally, whenever there were any complex tasks that were really memory and attention intensive, that a quiet space was made available. All right, with that, I'm going to pass things forward to Carmen to finish off today. Thank you.
Thank you so much to the speakers, and please use the chat box to direct message to questions with any questions. We already have a couple in the queue, and we'll get to our Q&A session in just a moment. Just wanted to remind everyone of the practice resource that is available on our website, as well as on the SharePoint site. And this is a document that will be updated over time. It includes proposed screening tool use, more detailed treatment considerations, and recommended outcome measures. And the resources being spoken to during this whole presentation, as well as the recordings of the session and the slide decks, will eventually in the next few days all be available on the external facing COVID-19 recovery and rehabilitation webpage, as well as internally for AHS staff on the link here to the Allied Health Practice and Education Hub under the COVID tile. And as always, anyone can email the practice.consultation@ahs.ca as the practice consultation service for questions that cannot be answered locally within your team and area. Please direct Albertans to call the rehabilitation advice line to speak with an occupational therapist or physiotherapist about individual rehabilitation needs, as well as access and wayfinding support, as well as the mental health line for a 24-hour, 7-day-a-week confidential service that provides support, information, and referrals to Albertans experiencing mental health concerns. Please note that this is the July 6th session, and we still have 2 more upcoming sessions on July 13th and 20th. Please feel free to tune in to any of the prior recorded sessions, as well as those upcoming sessions. The same Zoom link will apply for each week. So now we'll move into our questions. There is a question for Judy, circling back to our Edna case study. And the question is sort of about pushing through, trying harder. So the question is, was the family open to education on energy and pacing and adjusting their expectations around pushing through, trying harder? It seems to be a common theme and difficult for everyone to shift this paradigm, patients and clinicians alike. Judy, do you want to take that question?
Yeah, sure. So yeah, that's a really great question. I was really lucky in that, this client's family was very supportive, and, one of the daughters having a healthcare background in nursing, she was kind of well equipped to be a good support for her mother. I think the education piece, I can respect that from the daughter's perspective. There was a point at which her mother was extremely sick. This client was thought to be palliative at some point. And now she's making these gains. She's progressing quite quickly in terms of her physical abilities. But, it's really hard for an outsider to appreciate that fatigue component and that anxiety component. And that's really what I hope that case study kind of highlighted, is that, if you want to support someone in their recovery, it's not just about pushing them forward, but finding that balance between pushing them enough and also having them, rest enough, take a step back, integrate breaks. So, I mean, my experience was very positive. I think once you introduce those pacing principles, families are pretty good. I also think there's a variety of tools out there. So again, there's numerous worksheets. There's worksheets that involve assigning a number of points to a client. So, they try and establish a number of points where they hit their maximum, and then we make sure that we don't go above that limit. So, so we used a number of points just to kind of gain awareness and give some kind of quantifiable parameters for the family to work with. And in this case, it was very well received. So I would recommend most clinicians to consider that pacing perspective, whether it's physiotherapy, occupational therapy, or any other discipline.
Thanks, Judy. I'm just going to add to that to circle back to the June 15th session on maximizing energy and returning to daily activities and meaningful occupations. If anyone has questions or wants more information about pacing and maximizing energy, that session provided lots of practical tips and an overview. So now the next question is for Samita to take. Samita, you've already answered this one a little bit in the chat box in the background, but because we have time, let's do it verbally as well. So the question is there evidence that COVID-19 affects cranial nerves? For example, could the loss of smell or taste be related to the olfactory nerve versus the olfactory bulb?
Sorry, as I said in the chat to you to pass on, I don't know if there's any definitive evidence, but I am not an expert in all of these areas. But one of the hypothesized mechanisms is that it would the virus could get through via the olfactory bulb. So I guess that is my answer to that it might go from the nasal neuroepithelium into tissue into the olfactory bulb. And that could, of course, explain why many patients do experience problems with loss of smell. So that's my answer.
Thank you so much. All right, I'm not seeing any other questions coming in, but I encourage people in the last few minutes here that we have to please go ahead and ask any other questions, to direct message to questions, and I'll be able to pick that up if you have any other inquiries for our speakers today. Okay, I think we've created a good stir today and provided some excellent information for people to reflect on in their practice. Really important to think about the impact of COVID-19 on memory, complex attention, and executive skills specifically, and really drilling down to meaningful day-to-day activities and sort of that functional approach. And I really want to thank the speakers for doing such a great job at pulling this presentation together today. There is another question coming in, Judy, about would you be willing to share a link to the pacing worksheets that have been useful? Is that something that you have quick access to? Otherwise, I can follow up with the individual who's asking that question and we can forward information after today.
Yeah, absolutely. I think, weren't we also putting together kind of resources? I don't know if you can comment on that, Carmen, but I thought there was kind of a resource sharing area that.
Yeah, the website for one, and there's also self-management resources available on the COVID-19 webpage as well. That's external facing, available for everyone, as well as on My Health Alberta. So anything patient facing, absolutely those resources are available, and provider resources as well. I would also suggest going back to that maximizing energy session. There were some links and resources shared during that presentation. And I know who's asking the question. It's a Nicole. So Nicole will follow up with you with any additional links.
Just email me and I will get it to you.
Yeah, perfect. If you can email Judy, if you want to just maybe put in the chat box your email address, Judy, and that way Nicole or anyone else that's wanting links to that might be able to follow up with you. Quick question in the last half a minute here for Kevin. Any treatment ideas for patients that are more tangential in their cognitive communication skills?
Yeah, I mean, I think a lot of these patients that we're starting to see within Alberta and also hearing about in the literature, they are certainly showing evidence of the types of behaviors that we would see with somebody who has had an acquired brain injury. It's, you know, or a traumatic brain injury, or somebody who has had a more diffuse sort of encephalopathic bleed, that kind of thing. And so I think the strategies that we tend to use with people with traumatic brain injury, that kind of approach is very, at least in the early kind of acute, post-acute stages, very appropriate for these patients. As far as working on tangential behavior, yeah, I mean, I think we always want to use sort of a, whenever possible, a metacognitive approach where we're trying to increase patients' awareness of their behaviors and then trying to get them to monitor that in very, initially very structured, conversational type tasks, where we do a little bit of discussion. The patient, you're asking them to try and monitor. There's the debrief afterwards to find out what they think about how their performance went. That's sort of the type of approach we want to be thinking about with working on something like tangential speech.
Thanks, Kevin.
Sure.
Great response. And thank you so much again for everyone's participation today. We'll sign off our session today and look forward to seeing you at the next couple sessions coming up. Have a wonderful day. Bye, everyone.